think I've met some of you, but not all of you. As I'm getting older and having children, my memory gets even worse. So if I don't immediately recognise anybody or remember people's names, I really apologise. It's brilliant to be back. As Brian said, I'm a doctor. I'm a consultant clinical geneticist at Liverpool Women's Hospital and Alderhay Children's Hospital. And during my training, I did a higher degree, an MD, and I did that on Patella syndrome. Now, I haven't got Patella syndrome, and I haven't got any relatives with Patella syndrome, but I came across it in my training and found it really interesting. And so I went all around the country, visiting some of you in the audience, and really learnt so much about Patella, and put it all into a research paper, a thesis, and tried to then translate that into English for not only patients but also doctors who don't understand the condition. I'm glad to say that study was done before I had children, because we were travelling between sort of like, when I say we, it was me, that's a bit of a royal we, from Aberdeen was the most northerly point, Cornwall, Isle of Wight, so I got very used to travel lodges and motorway service stations. So, on to the information. As Brian says, I've tried to keep things as sort of as understandable as possible. If I say anything that you don't understand, please don't worry about sort of shouting out and trying to get clarification. And if I'm going too fast, also give a shout. So Patella syndrome, it's said to be something that affects about 1 in 50,000 people. We don't really know where that number comes from, and it may well be an underestimate. 1 in 50,000 would mean there'd be around about 1,000 odd people in the country with it. During my particular study I wrote up, I saw 123 people, but since then I've been to various conferences and I've probably seen about 500 people with NPS now, and that's just at conferences. What we do know is a lot of people only find out later in life, when somebody else in the family gets diagnosed, that they've had it all their life actually. So it may be underdiagnosed. So the other names for Patella syndrome, NPS obviously, sometimes it's called onychosteodysplasia. Onycho means nail and osteo means bone. HUD stands for hereditary onychosteodysplasia, and because of one report by a Dr. Fong, for a while it got called Fong disease. So, as you probably know, NPS is really variable, and it varies between families, and also it varies between people in the same family. So one person in the family might have problems with their knees and another one problems with their kidneys. So I'm going to talk a little bit about the clinical features of Patella syndrome. After a bit of a break, I'm also going to do a bit about the genetics, and I'll try and keep it simple, but I think it's quite important to have a basic sort of understanding on the genetics, because that will help you understand and answer some of the questions people may have about the inheritance and things. So firstly, in terms of the clinical features. Okay, so in terms of the clinical features, obviously, as the name suggests, the nails are one of the most obvious things to be affected. The patellae, they're the kneecaps. The elbows are also affected, and also other joints and the back. There's these characteristic things called iliac horns, which I'll mention later. The kidneys can be involved, and the eyes. And all of the features I'm going to mention, none of them are compulsory, so you don't have to have features in all of these areas. And the last one that's been more recently discovered is the involvement of the brain and the nervous system. So if talking about the nail changes first, that's the most constant feature. So nearly everybody with Patella syndrome will have some changes in the nails. Now sometimes they're less obvious than in other people, and so it takes somebody who's seen Patella syndrome before and knows a bit about it to really say whether they're affected or not. They're abnormal from birth, So quite a few people have said to us that when they've had children, the first thing they ask the midwife is, what are the thumbs like? And the midwife's looked at them a bit strange, but you can tell from birth. And they can be small, absent, ridged, split, discoloured, or spoon-shaped. And if you look at the involvement of the nails, it's always the thumbnail that's the most severely involved, and then as you move round to the other fingernails, it gets less and less involved all the way to the little finger. And the fingernails are usually more severely involved than the toenails. Now the ulnar side of the thumbnail, that's the little bit that's closest to the finger, that's the side that's involved the most. So if you look at your thumbnails, if you've got a bit missing or if you've got a bit that's abnormal, it's more likely to be the side that's next to the finger. Feel free to shout at me if you're different. So it's a really, really variable condition. I've just got some pictures here. So you can see here, the side that's next to the fingers is the most severely affected. And you can see here that it gets better as you go towards the little finger. And so in my study, 98% of people did have nail involvement, but for nearly half of them, all they had was their thumbs involved and their other fingernails were normal. Another little clue to the diagnosis, I don't know how well this shows, but can you see the little moons? They're called lunules. So they usually are half moon shaped, but in nail patella syndrome they're triangular. So sometimes you can't actually see the moons of your nails, but if you can, then they're likely to, at least some of them, have this triangular shape. And you can see here there's some toenail involvement. Now loads of people have got sort of crusty little toenails, let's say, in the general population, so that's not a very specific thing. But you can see the other toenails here are more typically involved. And it's not just the nails on the hand that are involved in nail patella syndrome. If you look at the back of the hand, you can see that there are less creases over the end joints of the finger. So you can see here this little boy, so he's got normal creases over the nearest joints in the fingers, but the furthest joints, there's no skin creases over those furthest joints. And also, if you try and bend your fingers, if you try and bend them like that, this is what I asked this person to do here, you can see that the end joints of the fingers don't bend quite as well. And so that's what this loss of DIP, this stands for distal interphalangeal joint. Doctors have got to give these big words to things to make themselves sound clever. I'm still trying. So that's what this means. Now, clinodactyly, that's a little bend in the little finger usually, and that can be seen in lots of different conditions and can be seen in the general population, but actually it's a bit more common in nail patella syndrome. Now, I don't know whether any of you can do funny tricks with your fingers. So this medically is called swan necking, and you can see here that this joint, what we call hyperextends, so it bends back, and this joint here flexes. And that's to do with the way the tendons are programmed to form in the fingers. So knee problems, a lot of people had knee problems, and it can be pain, clicking, locking, instability. And sometimes the kneecaps, the patellae can dislocate, and sometimes that can happen a lot. It can happen repeatedly. And even if the kneecaps don't dislocate, if you compared them to somebody else who didn't have nail patella syndrome, the kneecaps would be placed higher, so superiorly, and laterally, so they're placed higher up on the leg and also out towards the side a bit, and they're smaller. So you can have nail patella and have a completely normal sized patella, or it can be small, or it can be absent. You can also get tight hamstrings. So in some people, the children are born unable to completely straighten their legs because the hamstring tendons at the back of the knee won't allow the knee to straighten. and also that you're more likely to have knock knees or bow legs in children. Some people said to me that when their children were born, it looked like their legs were on backwards, and that actually reflects what we call a rotational deformity, and it's a bit like a sort of a severe club foot, and they can look like they've been twisted right round. This is obviously in the sort of a severe end of the spectrum, but it can be so variable. So these are some pictures of some of the knees that I met on my travels. So this little girl here, this is sort of one of the severe end of the spectrum of not being able to straighten the leg properly. This little girl had actually had surgery already. When she was born, she couldn't actually straighten her legs beyond 90 degrees. So she'd had treatment with frames to straighten her legs to that extent. So that was a good result for her, but she was having ongoing treatment. And I've sort of shown you the most sort of dramatic end of the spectrum as an illustration, but I must emphasise that it is incredibly variable, and some people don't have any problems with some of these areas. This chap here, these are his kneecaps over here and over here, so they're out of joint. And if you look at the knees bent, you can see here's a kneecap dislocated off to the side and also over here. And about 3/4 of the people that I met did have some symptoms from the knees, but 1/4 of people didn't have any symptoms from the knees at all. Prominent tibial tuberosities, that's something you have to have your teeth in to say. So these are these little bony sort of lumps at the front, at the top of the shin, and these are quite prominent. And in fact, this chap didn't know he had nail patella syndrome until he went to his GP, said, oh, these lumps are bothering me, can you do something about it? He got referred to an orthopaedic doctor who diagnosed nail patella syndrome. So it's quite funny how people come to a diagnosis of nail patella syndrome. Loads of people come to it differently. A couple of people have diagnosed it in themselves. One person read an article in Bella magazine and realised that's what she got. Another person had bumped into somebody on holiday who also had nail patella syndrome, and they said, excuse me, do you know what you've got? So it's often underdiagnosed or diagnosed late. So back to kneecaps, this is an x-ray taken, a side view x-ray, and you can see here a tiny little kneecap, and it should be sort of in the region of that size. And about 3/4 of people had small kneecaps, and only 9% of people had no kneecaps at all. This is an MRI scan, and this is a picture taken, it's like sort of chopping through the leg that way, and this just gives you another view. You can see here these kneecaps are small and sort of an unusual shape, and also dislocated off to the side. These are more MRI scans. This time it's like it taking a slice this way, and you can see here a small kneecap. This is the front and this is the back, and another small misshapen kneecap, and that's more of the same. So you can see there's quite a difference between, this is normal, so this is what it should like, and it's quite thick, quite broad from the front of the knee to the back. But in nail patella syndrome, the end of the thigh bone, the femur, it's quite sort of a squashed appearance, and there isn't a big dip keeping this kneecap in its socket, whereas normally there's a bigger dip and better tendons keeping it in its socket. And also the muscles are different in nail patella syndrome. A lot of people, when they go for surgery, their surgeons, if they don't know anything about nail patella syndrome, they'll go in and they'll look and they'll think, good grief, the anatomy is completely surprising. It's not what I expected to find, because it doesn't just affect the bones, it affects the patterning of all the muscles and the nerves and the blood vessels. And so you can see here, this is the sort of the pattern of muscles that you usually see on an MRI scan, and you can see here it's a very different pattern. The anatomy is very different, and that's why one of the recommendations we make is that before anyone has any sort of heroic surgery on any joints, the person doing it really needs to know a bit about nail patella syndrome and perhaps have done an MRI scan so that they really know the roadmap that they're working with first. So elbow problems. So one of the main problems with the elbow is a contracture. So that means you can't fully extend the elbow, you can't fully straighten it. Even if you can fully straighten it, what some people say is you can fully straighten it, but they have difficulty turning their palm up to the ceiling. And medically speaking, that's called supination. And they say that that's a bit of a pain when you're sort of going to get change or a drive-through, or I don't know whether anyone lives anywhere where there's like tunnel tolls or something. You can tell I'm from Liverpool, so we've got the Mersey Tunnel, and so you have to sort of put your money in or get change, and it's quite difficult if you can't extend your arm and you can't turn the palm over to get change. You're sort of having to do it like that, so I don't know whether any of you have sort of come across that. Now, another posh Greek word, pterygia. So that's a word for webbing. So if you can't fully extend the arm, sometimes you get a web of tissue across the joint. It's really variable, this condition, so some of you might have not had any of these issues at all, but some people are unable to straighten their arm, and there's like a web of tissue across it that blood vessels and nerves can run in. Elbow problems. A lot of people don't have pain, but some people do have pain and have significant pain. And surgery for elbow problems can be problematic. Sometimes it's better for pain, but a lot of people who've had surgery to try and straighten the elbow have actually sometimes come across more problems after the surgery than before. So it's something to, think very carefully about before going into. And it's the radius that tends to be the problem in nail patella syndrome. So it usually sits up here, but this is dislocated inferiorly, so below, and out the back. And some of you may have a funny little bump at the side of your elbow that other people don't have. That might well be the head of your radius bone that's dislocated. So as I say, you can have operations for your elbow. It's problematic. It's better for pain than it is for trying to get it straightened out. So iliac horns you've probably heard of, or you may not have heard of. These are things that you only get in nail patella syndrome. So if you see an X-ray with iliac horns on, that person has got nail patella syndrome. And what are they? So they're sort of bony, cone-shaped projections off the back of the iliac bones. And if you think of the pelvis being a bit like an elephant's head, with big elephant ears, it's the elephant ears bit that are the iliac bones of the pelvis. And I'll show you some pictures. You can actually feel them in about a third of patients. So one of the things I did on my study was go around sort of feeling on people's bottoms, trying to feel these horn things, but you could only feel them in about a third of patients. Bilateral means that they're present on both sides, and they don't usually cause any symptoms, they don't usually cause any problems at all. It's just a clue to the diagnosis. And they're present from birth, and in fact you can sometimes, if you know what you're looking for, you can actually see them in the womb. So some people have been reported in the womb to be able to see these iliac horns, and they're only found in NPS. And they're present in about 70% of people, but all it is a clue to the diagnosis. It doesn't actually cause any problems, nothing to worry about. Here's another picture. So you can see these nice sort of triangular things, and this is a picture of them side on. There's some smaller ones, so you can imagine if they get even smaller than that, they're quite difficult to see. And this is what they look like on an MRI scan. So this is like a chop right the way through the pelvis, like that. And you can see these bony projections, and they're just surrounded by muscle. Some people have other problems with their pelvises, and various things have been reported. Problems with the sacroiliac joints, unusual shape of the pelvic bones, and sometimes general changes to the shape of the pelvis can sometimes mean that ladies may have a higher chance of having a caesarean section that is by no means everybody gets a cesarean section, but it's one of those things that it's worth the obstetrician thinking about, making sure that the pelvis shape's okay. Loads of people have normal deliveries though. So another thing that you can have in nail patella syndrome is club foot, which the medical term for that is talipes. And this is present in about 20%, and it's often present on both sides. Most of the time it's amenable to casting and physiotherapy. Occasionally it needs surgery. And actually, in terms of what you can pick up on an ultrasound scan in the womb, club foot is one of the only things that I've sort of heard reported in terms of being able to predict whether somebody's got nail patella in the womb. Flat feet are really common in the general population, but a bit more common in nail patella syndrome. Sometimes even if you haven't got any problems with your feet, a lot of the parents said, well, my children are always walking on the toes, so even if they haven't got club foot, and sometimes that can be related to the Achilles tendon at the back of the foot, they can be a bit tight, so there's an increased tendency to toe walk. Back problems. Again, I'm showing you all the most extreme things, so I hope you don't find it too shocking or depressing. This is by far the sort of the worst end of the spectrum, and a lot of people don't have any of these problems. So this little girl here, actually, bless her, she had 2 genetic conditions. She had nail patella syndrome and something called neurofibromatosis, both of which can give you scoliosis. So scoliosis is something that you can have in nail patella syndrome. It's not usually this bad. About half of the people that I met had some pain in their back, and about half had what we call an increased lumbar lordosis. Now, a lumbar lordosis is if you sort of stand side on, everybody's got like a little curve in the bottom of their back. In nail patella syndrome, that's a little bit more marked, and a lot of the girls say it makes me look like I'm sticking my bum out or my belly. And as I say, scoliosis is quite an unusual feature in nail patella syndrome. So, other spinal problems that have been reported, something called spondylolisthesis, and that's when the building blocks of the spine, the vertebrae, slip a little bit on top of each other. Spondylolysis, which is like a breakdown of some of the bony parts of the spine. You can have fusion of the vertebrae. Spina bifida occulta. Now, what that is, you've heard of spina bifida. It's a sort of a problem with the tube of the spine failing to close up early on in the development of the baby. But spina bifida occulta is the most tiniest little sign of it that you would only pick up on an X-ray. It doesn't cause any problems, and loads of people in the general population have got it. So it may be actually not that linked with nail patella. It might just be coincidence that people have reported it. And because the joints aren't formed the way they should have been, they're more likely to get wear and tear arthritis and early degenerative changes. So people are more likely to get arthritis a little bit earlier than they would have otherwise if they've got some abnormal joints. So people have had various treatments for their back problems, analgesics, that's painkillers. Some people have had epidurals or spinal blocks. Some people have had a lumbar brace, rods in their spine if they've had a scoliosis, and some have had fusions of the spine. Chest wall abnormalities, these aren't common in nail patella syndrome, but they do occur. Pectus excavatum is a little dip in the chest bone. And this chap here, you can see there's a dip in his chest bone here. He's actually already had surgery, so that's the after rather than before. So before he had the surgery, apparently there was only 2 inches between the front of his chest and the back, and he used to get quite out of breath, even just walking upstairs.
What's the question? That was in brackets.
Yeah. Yeah, so the numbers in brackets are, it's 14 people out of 39 people. So although there was 123 people, not everyone got examined for everything. So when we knew we'd looked for it, we could then give a number of those people. Yes, so sorry, I should have explained that to begin with. Okay, so some of you might have heard about or might have noticed a characteristic body shape and hair pattern. Again, it's present in some people, not present in others. And people often sort of complain about a decreased muscle mass in the upper arms and the upper legs. It's not something that girls often complain about, some people do, but it's often guys who, even if they go down the gym, really can't develop the muscle mass up here or in their thighs because it's they just haven't got the programmed muscle bulk that they should have. The increased lumbar lordosis I've mentioned, so the tendency to sort of have your bottom sort of sticking out a little bit. Sometimes as a baby particularly, and maybe later on in life, there's a tendency for the head to appear slightly bigger than the rest of the body. It's mainly as a baby, and some of that's to do with having a prominent forehead, and some of it's to do with, although it's not a short stature condition, growth is very slightly affected in Neil Patella syndrome, but head circumference isn't. So there's a tiny, tiny bit of disproportion between the head circumference and the growth generally. Brian's already mentioned the high forehead. Sometimes if you look at girls, some of the girls that I came across were a bit self-conscious about their hairline and had grown a fringe. Some people not self-conscious at all. But if you have a look, often there's what we call like a widow's peak, so it tends to be lower in the front and higher up there at the temples. And a lot of people said that as babies they had very thin hair and took ages for their hair to grow. And as I say, the average height was on the 25th percentile. So what if you imagine that, I don't know whether you've seen centile charts, if you've had babies and you've gone to the health visitor to get the baby weighed and measured. The 25th percentile, above that line, there would be 75% of people would be above that line, and below that line would be 25%, and average is about 50. So people are generally slightly smaller than their brothers and sisters, but the head circumference, which is the OFC, that's occipitofrontal circumference. Sorry, some of the jargon slipped in, I should have edited it. The head circumference is usually normal. Okay, so these are some of the people I met on my travels. This lady here, you can see the sort of the typical hairline in her. And this chap here, actually, this is another sort of weird way people are diagnosed. He actually was thought to have a form of muscular dystrophy and was referred to a neurologist for the investigation of his muscles. And then when this, doctor had a closer look at him, he saw past the muscles and saw that he actually had Neil Patella syndrome. So you can see here the muscle bulk isn't as bulky as usual, and he had sort of problems building up his thigh muscles as well. A lot of people said they were bendy and they could do various party tricks here. That tends to be more so in childhood, and children are generally more bendy than adults, but also in the finger joints and things. Some people said that they could actually dislocate their hips in and out without much pain. And also joint laxity tends to lead to the ankles and the knees being a bit unstable, and some people say that their sort of knees give way. Some people have dental problems. That was something that wasn't previously reported, but I found quite a bit in my travels. And their dentist had told them that they had thin enamel and they had weak crumbling teeth and sometimes early loss of teeth. And about sort of a quarter of the people I met had some problems with their teeth. So I was going to talk a little bit about kidneys and eyes and things now. Okay so far? Anyone got any burning questions? Are we okay for time? So this is a pretty picture I thought I'd put in of some of the cells that are important in your kidneys. So your kidneys are basically a filter to filter out all the bad stuff in your blood and keep the good stuff. And some of the cells that are important in doing that are these like octopus type cells called podocytes. And you can see they've got these legs which branch, and you basically get all the branches meeting to form a really good sieve or a filter. And when that filter's working properly, it shouldn't let too much protein through. However, in Neil Patella syndrome, those foot processes are abnormal and the filter gets leaky and protein comes through. There we go. So, kidney involvement. About 30 to 50% of people with Patella syndrome will show some signs of it affecting their kidney, and those signs are in the urine. It may occur at any age, so from birth, little babies can show some protein in the urine. And proteinuria is the word for protein in the urine, and that's usually the first sign of kidney involvement. And it can remain benign, so in other words, not causing any problems. And in most people, it does remain benign and not cause any problems. But in some people, it can progress to what we call nephrotic syndrome or nephritis. And the good news is that only 2 to 5% of people actually get kidney failure. So that's good. So most of the time, it doesn't cause significant problems. So kidney failure, if it does happen, might need dialysis or very occasionally kidney transplant. But the good news is, even though it's rare, when it does happen, kidney transplant's usually successful, and you don't get Patella kidney problems in the transplanted kidney. So some kidney problems, if you transplant a kidney and put it back in a person with a condition, that new kidney gets the disease, but not in Patella syndrome. So if you put a new kidney in, that stays healthy usually. And there's characteristic appearances on the kidney biopsy. So sorry.
Can I ask why you say 2 to 5%? Is that based on more than one study?
Yeah, it is. So in my study it was 2%. Other studies have shown higher incidence. So yeah, so if I ever give a range, it's because there's lots of different studies. But it's a low chance, so I don't want anyone getting, scared or anything like that. If you do have a kidney biopsy, it looks like this. Don't worry, I won't get too technical, but this is normal. And the thing that is affected in Patella syndrome is around here. It's the glomerular basement membrane, and it usually should be sort of quite uniform with no sort of bits in it. But with Patella syndrome, this is a bit of a closer up view. You can see it's sort of patchy and thickened, and you can see these black bits in it, which are clumps of collagen that forms in the Patella basement membrane. So in the study I did, about a quarter of people had some kidney problems, and if you looked in people in just the older age group, that went up. So that just is an indication that it can come on later on in life. And only 2% of people in my study actually had kidney failure. The average age that kidney problems were detected was 22, but that ranged from one person problems were noted as a baby all the way up to 51. So it can come on at any period of time. I will whiz through those because they're a bit more technical. Treatment. So some people are on a drug called angiotensin converting enzymes, ACE inhibitors. You might have heard of those. They can help with the protein in the urine. You wouldn't be put on those straight away. That would only be if it was quite significant protein in your urine. And as I say, if it needs to get to a kidney transplant time, then that's usually successful. Some people ask about low protein diets and things like that. There's no evidence that that has any effect, so that's good for those of you who like sort of steaks and hamburgers and things like that. One thing that is worth noting is preeclampsia, which is a condition that affects pregnant ladies, which is increased blood pressure and various abnormalities in the blood and the urine. That's much more common in Patella syndrome than the rest of the population. So if you're a lady undergoing a pregnancy, they need to keep an eye on your blood pressure and things. And also pregnancy may be a time that the kidney problems show themselves up for the first time, and it might get better after the baby's born. Right, quickly about the eye. So this is a cross section through your eye. So this is the front of the eye and this is the back. This is the lens in the middle. And the bit that's important in Patella is here is the optic disc, and here where the fluid's made. So the problem in the eye with nail patella syndrome is glaucoma. So you've probably heard about that. Oh, it's done that again. That's because I've pinched some of these off the internet. Okay, so the reason you get glaucoma is because of a build-up of pressure. And the build-up of pressure is caused by the fluid not draining properly. So fluid is made here in the eye and circulates all the way around and is absorbed here. And the cells that are here at the front of the eye in nail patella syndrome don't work properly. So fluid builds up, pressure builds up, and when that pressure builds up, that can have an effect on the back of the eye. So this is all a bit technical as well. Glaucoma, it's a multifactorial optic neuropathy, which is there and characteristic acquired loss of optic nerve fibres. Now, in English, what that means is that the optic nerves, the cells in the optic nerve gradually die because there's pressure on them. And what happens is you lose the vision in the peripheries first, and then it closes down and becomes tunnel vision. And one of the reasons it's really important to get screened for glaucoma is that at first you won't notice any loss of vision in the peripheries. It's something that people don't notice much. But once the cells have died, then you won't get those cells back. So it's really important to be screened for glaucoma. So when you screen for glaucoma, they will look at the optic disc here, and it's meant to have, this is the optic disc, and there's a little cup in the middle of it, and that little cup is meant to be quite small. But as the pressure builds up in the eye, it's a bit like a balloon, and the bit that you tie a knot in the balloon is like a weak point. The pressure builds up, and that weak point gets pressed, and the cup gets bigger. And as the cup gets bigger, all of the nerve cells that run from the retina that go through into the optic nerve, they all get pressed on and they can die. And so the nerve cells supplying the peripheral vision are the ones to go first. So if glaucoma is usually caused by increased pressure in the eye, you can sometimes get what's called normal tension glaucoma, so the pressure's okay, but you still get this disc cupping, and that's why if you get screened for glaucoma, it's important not just to have the pressures measured, but get them to look at the back of the eye and make sure that there isn't any of this cupping. And there's also something called ocular hypertension, which means that the pressure's there, but it's not caused cupping. So basically, get properly screened for glaucoma, not just the pressure, get them to have a look at the back of the eye, and also get them to do your visual fields. Some of you might have had it done at the opticians, so you have to look into a little box and they shine little lights and you have to press a button when you see them. So that's a really good sensitive way of seeing whether your peripheral vision's okay. So how frequent is it? Well, in the over 40s I looked at in the study, nearly 30% of people did have glaucoma or ocular hypertension. So it's more common, and it also comes on more at a younger age than the general population. So a lot of people get glaucoma in the 60s, 70s, 80s, but it comes on much sooner in nail patella syndrome. So the average age of detection for the glaucoma was 48. But there was a range from the youngest person in the study was 23. I've also met a 17-year-old who was just diagnosed as having glaucoma. So it's not just an old age thing. Leicester's sign you might have heard of. So if you sort of look deep into your eyes, you can see the iris, the blue bit or the brown bit. Often there is this, it's called a cloverleaf pattern. I've never seen one look like a cloverleaf. It's more like a little flower. And that's an area of darker pigmentation around the eye. It's very non-specific. You can get it in the general population, but it's more common in nail patella syndrome. And here, can you see this, ladies? So you can see this sort of darker area of pigmentation. I think it's quite pretty, actually. Okay, I once made a real boo-boo at a conference. It was the first time I'd spoken about nail patella syndrome to the medical community. It was a great big international skeletal dysplasia conference. I was a little trainee registrar in Oxford, and I was trying to emphasise that when I was talking about constipation, it wasn't the usual constipation that people had from time to time. I was saying, it's not bog standard constipation. And Ian McIntosh set everybody else laughing, and I was like dying, but it woke people up. So the constipation isn't bog standard constipation. A lot of people need sort of quite strong medication. Occasional people have had enemas and things like that. Irritable bowel syndrome is really, it's common in the general population, irritable bowel syndrome, but it does seem to be more common in Patella syndrome. But again, 70% of people had no bowel symptoms. Neurological problems are more recently known about, and they were present in a quarter of people, and people complained of like tingling for no particular reason. So it wasn't like you'd slept on your elbow and woke up and your arm had gone dead. The tingling just came on for no reason. Sometimes numbness, and it was usually at the ends of the arms or the ends of the legs, so the hands and feet, and it wasn't in a particular distribution of any particular nerve. And this is just the results of one study looking into the neurological problems and how frequent it was. So some people had a decreased sensation to pinprick. It sounds terrible, doesn't it, like sticking pins in people? It's one of the ways they assess sensation, and decreased cold sensation and decreased vibration sense. A lot of people talk and will ask me about learning difficulties, developmental delay. So in my study, 8 people had some difficulties, 2 with mild learning difficulties, some with ADHD, speech delay, dyslexia, dyspraxia. My feeling is that that's just the normal population. I don't think Patella syndrome causes learning difficulties. In terms of ADHD, there's probably evidence now that ADHD is more common, and it's more common in children and it's more common in adults. However, if you talk to Americans about this and if you talk to British people about this, there's a slight difference of opinion. I think nearly everyone in America's got a diagnosis of ADHD, and all the kids are on Ritalin and things like that. So there are some differences in opinion, but I do think it's probably real. I think there is a slight increased chance of ADHD, but I don't think learning difficulties or anything like that are associated with Patella syndrome. So, peripheral circulation, they're called vasomotor problems. A lot of people had poor peripheral circulation, so I don't know whether any of you feel that even in warm weather they've always got sort of cold hands and feet. And some people have Raynaud's phenomenon, which is where there's a colour change in the hand, so it might go from pink to white to blue. Disability, quite a few people that I met had been actually registered disabled, and it was often not due to knees or elbows, it was often due to back pain, and occasionally people had to use wheelchairs or stair lifts. Another thing that people have looked at is the incidence of depression. Now, this is a difficult area as well because depression's really common in the general population. You can get it in Patella, like you can get it if you haven't got Patella. So I don't know whether there really is a link with depression. And obviously, if you've got a chronic disability and you're chronically in pain, you're going to get down about it. So it's quite difficult to unravel what is, the same incidence that anybody could have depression with and what it's like just to have a lot of pain. So to come to the end of this bit, what do we recommend in Patella syndrome? Firstly, you get your kidneys and your kids' kidneys checked from birth. And what does a kidney check mean? Well, it's not an ultrasound scan. So some people say, oh, get the kidneys checked. We'll take a picture of them with an ultrasound scan. They're not a different shape, or they're not a different size. It's actually the function of the kidneys that needs looking for. So it's getting the urine checked for the presence of protein. Now, you can get these little dipsticks you've probably seen where you just dip it in the urine. That's a relatively, it's an easy way of checking for protein. The gold standard is actually getting it sent off by your doctor to a lab looking for something called the albumin-creatinine ratio. But if they're not doing that, at least if they're doing a dipstick and doing your blood pressure once a year, that's enough. And if you're fine, great, just get it done every year. If they pick anything up, then they should refer you to a kidney doctor, and they're called nephrologists. Glaucoma screening, so everyone should have that once a year as well. And as I say, make sure they check the pressures but also the visual fields, and take a look at the optic discs. So make sure they do all that. When to start that, I don't think it comes on early enough for it to be worth putting little kids through that. So I think as long as kids are sort of old enough to cooperate, sort of in adolescence really, in their sort of, early to mid-teens, if they get them, checked from that age really, I think that's reasonable. And in terms of glaucoma screening, if you've got a good optician and you tell your optician, look, I've got a condition that I'm at risk of glaucoma in, if they know that and they're looking at it, your optician's probably fine to screen you. But some people are under the care of an ophthalmologist, and that's okay as well. And as I say, before any sort of heroic joint surgery, I think it's a good idea to get you an MRI scan, just so that the surgeon doesn't find anything unexpected.